see you. So the question goes to Dr. Walsh. Is there any recommendations about the cleansing procedure during the era of COVID-19 pandemic, or any specific cleansing procedures during this time?
So there has been some research done in the adult endoscopy world, and they have shown that the regular kind of recommended cleansing procedures for the endoscope should kill the coronavirus. So there's no special cleansing procedures that are required. Between procedures, there is kind of an extra wipe down. I know at our hospital, the turnover times are slightly prolonged because there's increased wipe down of the surface areas. And there's also room turnover in terms of letting the viral particles dissipate before you have the next procedure.
Thank you. The next would be for Dr. Manfredi. Is there any recommended esophageal dilation interval in esophageal atresia patients with post-op stricture?
It's a very good question. There's no standard protocol for dilation interval. Typically, what I would recommend is for a tight stricture to dilate at least every 2 weeks until you start seeing improvement in diameter, and then you can space out from there. Once you can see that you can maintain an adequate diameter every 2 weeks, then you can space it out to every 3 to 4 weeks, and so on. The one thing you don't want to do is dilate and then once, and then have the patient come back 6 to 8 weeks later, and then you're back to square one again. So you want to do it on a very frequent interval. Sometimes I do weekly as well. I think it's safe to do weekly, but 2 weeks is satisfactory.
Okay. I think the follow-up questions from on-site from Dr. Widodo is it possible to use the stent if the esophagus post-op is not straight? Sometimes the result post-op is bent. And if there is any, what are things or aspects should be considered?
Yes, no, it is possible to use the stent in an esophagus that does have some curvature to it. I think you do have to be mindful of the edges of the stent and make sure that it doesn't seem like the stent is resting at one of the curvature areas, because that could definitely lead to erosion. The other thing to be mindful of is if there's any compression from vessels, such as the subclavian artery. It's sometimes seen an aberrant subclavian artery, and you want to make sure that the stent is not, especially the edges of the stent, are not compressing that. So I think you do have to be mindful of the angulation in the esophagus, but it's not a contraindication.
From on-site as well, Dr. Parkash, any techniques, difficulties, average duration for stent remove in cases of stent placed in the stricture? Techniques, difficulties, duration.
Sure. So I typically I do shorter durations before checking. So I'll typically leave a stent in for 1 to 2 weeks, and then would look again, remove the stent, and then if the tissue looks like it's healthy enough to put another stent in, you can do it then. I also will do periodic X-rays to make sure that the stent is in good position. And I think that's the one thing you should also do is go by patient's symptoms. If they're very uncomfortable with the stent in place, I mean, to the point where they're having trouble, where they're just needing frequent pain medication, then that's a reason to take it out much sooner, because usually that means that the stent is kind of digging into the esophageal tissue, causing an erosion. So be mindful of clinical symptoms, periodic chest X-rays, and I wouldn't let it go more than 2 weeks personally.
Okay. This question may go to Dr. Dharma or Dr. Walsh as well. Is there why there's the similar findings between EGD and colonoscopy in terms of reduction after or during the COVID era? Because EGD, you have to do put the patients on GA or intubated them. Why is it the same reduction?
I think at many sites in North America and Europe, at least, both EGD and colonoscopy are done under sedation. So I don't think that there's much difference in terms of practice around the sedation. I think there was some thought early on as well that EGD might actually be a higher risk procedure because it may have more potential to generate aerosols. So that may have been why those have reduced just as much.
Yes, from the result in the survey, stated about 42% reduction. In the 42% centers showing reduction more than 51% for gastroscopy and about 40% reduction, or more than 50% reduction for colonoscopy. So it's just about the same gastroscopy and colonoscopy. And consideration is, I think it's the same with Dr. Walls about the gastroscopy because they're all intubated, and I can add more because they're afraid about they still found the SARS-CoV-2 in faces, and then the colonoscopy, the eye fluid maybe consists of the SARS-CoV-2 as well. So they all reduction, not only the gastroscopy but also the colonoscopy.
Okay, thank you. Last question. Is the esophageal stricture, which is near the GE junction, is a contraindication for esophageal stent placement? Good question.
No, it's not. It's not a contraindication, but you do have to be more mindful of stent migration at that point. So definitely something to keep an eye on. The other thing to be mindful of when the stent is crossing the GE junction is there's increased risk of reflux for the patient, since you have GE junction is also stented open. But I very frequently, especially if the stricture is low, you have to go through the GE junction. So just something to keep an eye on.
Okay. Thank you, Dr. Walsh, Dr. Manfredi, and Dr. Dharma for the excellent talks and Q&A session. Thank you very much. So we'll have a 10-minute break after this before we come back for the next session. Thank you.